long. The title of this talk that was given to you is Psychopharmacology, and I'm definitely going to talk about psychopharmacology, but what I'm really going to talk about, because I believe that we have to integrate psychopharmacology and how we expand professional practice in general. So I'm going to talk about psychopharmacology in the context of the expansion of the scope of practice for clinical psychology, and where I really think we are going as a profession, and where I hope we are training you as students to acquire these skills to keep up with what I think are some fairly rapid developments in the profession of clinical psychology. I'm going to talk basically about three major contributions where I think psychological science has affected and continues to affect not only mental health practice in general in this country and around the world, but increasingly our involvement in the public policy process. So psychopharmacology is one such thing, and when psychologists became involved in this in about 1990 or thereabouts, and I'll give you a little bit of that history, we really became a player in the public policy process in a way that had not been the case for the profession in the past. If you go back and you look at the history of psychology involvement in public process, it's actually a fairly robust thing. At various points in our history, the contributions of psychological science have been more highly valued by the public than at other times. Anybody think of instances? They're usually not very fortunate instances. Often around the time of war, for example. So in the First World War, there was a great deal of psychological involvement and application of psychological science to doing what? Anybody remember? From tests and measures. The Army Alpha and Army Beta tests, which were designed to assess recruits' aptitudes. And that had a great deal to do with the screening selection process of people into the military. World War I, around the time of World War II, again, there was a great deal of involvement of psychology in screening people in and out of the selection process for the military. And then what happened is after Vietnam, we started to get involved in treatment and clinical and more clinical measures. After the Second World War, in the Veterans Administration's facilities, that's really where clinical psychology in the U.S. got its legs underneath it. But after Vietnam, we started to become more involved in direct service provision of psychological service and other services directly to service members in the combat environment. That's a different lecture, and I'd be happy to give it to you. But that is one example of how we've been involved. And since about 1990, as I said, our involvement in the issue of psychologists prescribing psychotropic medications has really had a fairly significant effect on public policy process, not only in individual states, but as we consider these things in larger environments such as the DoD, Department of Defense, and other large federal entities. How many states now allow psychologists to prescribe medication?
2.
I'm sorry?
2.
2, that's right. 2. The territory of Guam actually does. Nobody's doing it there yet. The state of Indiana actually has a provision to do that. Nobody's doing it in Indiana either. But now all of the Department of Defense does, and increasingly other federal sectors, such as the Indian Health Service, are allowing psychologists to prescribe. I also think we need to get involved in things other than direct provision of healthcare services. Public policy and using the example of large-scale climate change is another instance where I believe that the direct application of psychological principles to large-scale change will be of great benefit to the population at large as well as to policymakers. There's another good example of this. It's quite salient right now, today, in how psychologists are involved in setting national policy around large-scale change issues. Can anybody tell me what that might be? Pandemic illness. And if you go on to the web and look at the Department of Health and Human Services pandemic illness plan, one of the appendices, I think it's Appendix 12, is exclusively devoted to the psychological sequelae of pandemic illness and the kind of things that we can do to help ameliorate some of the effects of pandemic illness. Another big issue, and one that I hope that we're talking about more and more as we go through graduate education, is how we integrate psychological service delivery in contexts other than specialty mental health care. Okay? More and more people get their health care, mental health care, in publicly funded health care delivery systems, such as federally qualified health centers. Not mental health centers, health centers. And the average, or the modal patient in a federally qualified health center is a woman of non-dominant ethnicity who is in her 40s with a family. She's often single, but about 60% of healthcare seekers in federally qualified health centers are non-dominant ethnicity females with some significant social challenges, economic challenges, and dealing with issues such as single motherhood. These people do not go to private practice mental health providers. They don't. They do not seek out specialty mental health care. They get their mental health care in a primary care delivery system. One of the things I think we absolutely have to do as educators and as clinicians is learn how to integrate our knowledge, learn how to apply psychological science in the public mental health, in the public health system, okay? So we are truly integrated into the primary care environment, and we become primary providers of behavioral health services. That's actually a radical shift from where we have been as a profession. I think it's a very welcome shift and one that's happening around us. So I think it's really important that we think about what is necessary to train students and to train practitioners to work in that environment. Okay, so we're going to talk about psychopharmacology now. And the reason I want to talk about this now is because around us, and this is happening so fast that we really don't realize what's going on. We have really come to the end of the road in terms of current practice of psychopharmacology. We have, for the last 20 years or so, since about the introduction of Prozac in 1987, been living in something that people have called the antidepressant era, where antidepressants were universally dispensed, really, for a variety of ills, many of which had nothing to do with a diagnosis or presenting complaint of depression, and universally thought to be effective for the management of those conditions. That turns out not to be true. But the assumptions that we went into this in the 1980s, that we could identify a common biological foundation, and there was a determined biological final common pathway in depression and other serious mental illness, and that was the underlying ethos, that was our core precept. That's not true. And I'm going to tell you in a little bit about why that is not true. But we are facing that reality more and more today, and we look now not at what the ultimate biological answer might be, but the fact that we have really bumped up against, in many instances, the limits to the biological model, biological explanations of mental disorders. Okay. In the 1980s, there was a sociologist by the name of Helen Hacker. Some of you may have studied a little bit of her work in some of your courses. She very famously said that serotonin, and this was in the after the introduction of Prozac, of course, and the serotonin reuptake inhibitors, she said that serotonin was the phlogiston of the 20th century. And if you remember your history of science, phlogiston was this unknown element that created fire in the 18th and 17th century. People didn't know about the chemistry of combustion and the physics of combustion. And so they thought there had to be this thing out there that caused things to erupt into flames. They didn't realize the contribution of oxygen to combustion. So they called this thing phlogiston. And it was good for everything. And in a similar sense, we thought that serotonin was the answer to everything in the 1980s. It turns out very much not to be the case. So we are increasingly questioning about whether or not there is going to be this final biological answer to depression. And the answer, by the way, is not. I can guarantee you that no matter how hard we look and no matter how fine a microscope we apply to this, we are never going to come up with a single common biological denominator for depression. It doesn't exist. And I think that increasingly we can ask those same questions about other common severe mental illnesses. So we questioned the basic assumptions. That's a big deal. Then there are some more pragmatic things that are going on that we have to pay attention to. One of them is the fact that patents on most of the commonly prescribed psychopharmacological agents are expiring. Okay? All of the new generation of antidepressants, it started with Prozac in the 1980s, all of those patents are essentially gone. There are a few that linger out there, but most of them are entirely gone. What does that mean? That means that I can get that medicine in a generic form. I don't have to go out and look for Prozac. I can get generic fluoxetine at a fraction of the price that I would pay for a branded medication. That means that there's less impetus for pharmaceutical manufacturing companies to promote these treatments for mental disorders. And that's a significant variable because the creation of demand by pharmaceutical manufacturing companies is a very significant component in determining the use of that agent. And we create demand, interestingly enough, not just by educating physicians and other prescribers, but by telling the public that they need to be taking this particular medication. When the economics change and there's not that much money made by promoting a particular drug, utilization of that drug always drops. And it's very, very predictable. When you stop promoting a drug, when a drug loses its champion, utilization of that drug diminishes. Okay? Particularly in the case of things like antidepressants, because with antidepressants, their efficacy is not as great as they might be for certain other medications. So if you have a drug that's of rather questionable efficacy, that's really been propelled into the marketplace by a lot of activity on the part of pharmaceutical manufacturing firms, but then when people come back and say, gee, maybe this isn't quite as effective as we had initially been led to believe, that really affects how people think about those drugs, how people use them, and the rates at which they're used. Okay? There are two other pragmatic issues that really are affecting the today's practice of psychopharmacology. One of them has to do with this class of agents called second-generation antipsychotics, things like risperidone or quetiapine. The new antipsychotic agents that replaced the standards that existed from the 50s until the late 1990s, really. Things like haloperidol, Haldol, or chlorpromazine, Thorazine, similar medications. One truism in psychopharmacology has been that with every new generation of agents, the newer generation has a couple of characteristics. It tends to be much better tolerated by patients, and it tends to be a heck of a lot safer. Let's use the example of the tricyclic antidepressants. Introduced in the 1950s, mainstay of treatment for depression until Prozac and similar medications came along in the late 1980s. They were no more effective or less effective than any antidepressant we have today. Efficacy has remained unchanged. It is the same. But patients didn't like them because you had to take them several times a day. They gave you terrible anticholinergic side effects, dry mouth, weight gain, constipation, blurred vision, and the like. And they were really hard on patients to take. The third thing they didn't like, that doctors didn't like about them, was that they were extraordinarily lethal in overdose. Two pills of most common tricyclic antidepressants are enough to kill an infant or a toddler. Okay? So if they pick up something off the floor that's been dropped on the floor, 2 pills will kill an infant or a toddler. A 10-day supply is sufficient to kill an adult. So you can imagine that when we were giving these medications to patients who were already at risk for suicide, physicians were extremely reluctant to hand these out willy-nilly. Then we came up with Prozac, very, very safe in overdose. So its use expanded. But this is characteristic of all of these classes of agents. They become better tolerated by patients. We come up with drugs that patients can take more easily. They don't have to take them 3 times a day. They can take them once. And they're safer, except for second-generation antipsychotics. What was a big problem with the first-generation antipsychotics, haloperidol, Haldol, and others? What was the big worry that clinicians had about their use? There was one major side effect that scared the dickens out of everybody, as well it should have. Tardive dyskinesia, okay, which is a permanent neuromuscular deficit that people get after taking medications for a long period of time, various other factors that led to it, but a fairly significant portion of anybody who had to take a first-generation antipsychotic over an extended period of time was at high risk for developing these neuromuscular deficits called tardive dyskinesia. You would think, if it were an antidepressant, we would look for another drug that wouldn't have that side effect, but would still have some antidepressant efficacy or antipsychotic efficacy. And people have looked for a long time. They haven't found one. Every modern antipsychotic drug has a risk of tardive dyskinesia, just like the earlier ones did. These also have a series of other side effects that the earlier antipsychotics didn't have to such a great extent. But the bottom line is, these drugs are no more effective than the first antipsychotics introduced in the 1950s. And at making them different from other classes of medications, they are no safer. They're poorly tolerated, they are no safer, and they're no more effective than the earlier antipsychotics. People are recognizing this now because we spend a huge amount of money on these drugs. In some instances, 2/3 of a state's mental health budget goes to the prescription of second-generation antipsychotics. They're very, very expensive. $5, $7, $10 a dose or more. Whereas you can get a dose of haloperidol now for about a nickel, literally. So policymakers are starting to look at this and say, wait a minute. They're not safer. They're not more effective. They cost a heck of a lot more. What are we doing here? So that's a big change that we're having to face. Very, very similarly, newer anticonvulsants. What do we use anticonvulsants for in mental health treatment? Mood stabilization, right? Bipolar disorder, severe irritability or mood lability. These drugs are now being used. What was a classic drug for bipolar disorder or mood instability? No, classically, the one that first out of the blocks. Lithium, right. Okay, no, Abilify is actually an antipsychotic, not a mood stabilizer, but there are lots of them out there. Again, we're having the same questions about these very expensive new compounds, but no safer or more effective than the earlier compounds were.
I just have a quick question.
Yeah.
With the newer antipsychotics, so research is showing that, because I thought that theoretically they're supposed to be better at helping to control not just the positive,
right,
but also the negative symptoms.
Right. Right, and so does everybody know what Dr. Theodore is referring to when he talks about positive or negative symptoms of schizophrenia? So those symptoms which are positive symptoms, which are disorganized thought processes, hallucinations, and the like, were the classic target of antipsychotic drugs. Negative symptoms, which have to do with things like social withdrawal, apathetic approach, people who had really a very flattened affect, loss of executive functions really are the negative symptoms of schizophrenia. There was, and this was very, very highly promoted by the pharmaceutical manufacturers, a thought that the new second-generation antipsychotics were differentially effective for the negative symptoms of schizophrenia. Unfortunately, that turns out not to be the case, and it was probably had to do with the fact that people were getting very, very high doses of first-generation antipsychotics, which led to the production of some negative symptoms. Unfortunately, social interaction, social behavior, Alan Belloc at University of Maryland, you might want to go and look at his work, has looked at this in detail, and unfortunately, it's not a good answer. They don't really help negative symptoms of schizophrenia. We do tend to medicate people less heavily now than we did a couple of decades ago. That may have something to do with it. This is a very difficult slide to read, so I'm not going to spend much time on it. What this slide tells us is how often we prescribe drugs, and this is a global snapshot that comes from a company that tracks these things. And the take-home lesson from this slide is, of the 15 most commonly prescribed classes of agents of any kind, you've got antidepressants and antipsychotics coming in number 6 and number 7 on that list. Right now, according to these, these are the sales in millions, because antipsychotics are more expensive, they come in even higher, more often than do the antidepressants because they are so expensive. But that's a lot of medication that we are using. And here's just another breakdown of that, showing that 2 of the atypical antipsychotics, Seroquel and Zyprexa, remain among the most heavily prescribed drugs of any class. On this list, we do have one of the antidepressants, Effexor, venlafaxine. What you would have seen a few years ago is venlafaxine, Effexor, really right at the top of that list, and antipsychotics someplace down at the bottom or not at all. But because there's been so much marketing effort put into these drugs, you see them rise up on this list. Think about it. There are not that many psychotic people in the world that these drugs would be competing right next to things like agents that are used to lower cholesterol or to treat heartburn, some of the most commonly prescribed agents of any class. And this is another snapshot that shows these things again overall. And I won't spend any time on it except for to say, again, we have antipsychotics and antidepressants. Whether or not you measure in terms of volume of prescriptions or total numbers of, or the numbers of dollars that we spend on them, always come very, very high on that list. In the United States, taking another look at these data, I just wanted to show you a couple of things. Seroquel, the atypical antipsychotic Seroquel, in 2008 had sales of almost $4 billion, $3.9 billion. In 2004, sales of Seroquel were $2.1 billion. Okay, so what does that tell us in 4 years' time? We got twice as crazy in 4 years than we were in 2004. The indications for Seroquel are bipolar mania and schizophrenia. We have that many more bipolar manics and schizophrenics in the United States in 4 years. I don't think so. So what does that mean? It means that we are using this drug for many, many off-label indications, such as irritable mood, behavioral disorders in adolescence, and the like, sometimes even for sleep. Seroquel is used just to put people to sleep in spite of its negative side effect profile. And we're spending a heck of a lot of money on it. Lipitor, the cholesterol-lowering agent, makes about twice as much money, but $4 billion a year spending on these. People worry about the opportunity cost of doing this. How much of that $4 billion a year could go towards providing psychological interventions for patients who may need them? We are truly making a choice, and this is something that policymakers are becoming more and more aware of, that there is a real choice here, and there are real opportunity costs if we put all of our eggs in the pharmaceutical basket. Down here is another atypical antipsychotic, Abilify. You see the same pattern, $1 million in 2004, $3 million in 2008. When you look down here, these are 2 antidepressants, venlafaxine or Effexor, and escitalopram, Lexapro. Now here's an interesting story. 10 years ago, you would have seen a trajectory very similar to this. maybe doubling in size over 4 years. But look at this. In 2004, venlafaxine had $2.6 billion of sales. In 2008, $3 billion in sales. Okay? Hardly a blip. It just went up a little tiny bit. Why? It's going to go off patent. People are thinking again about antidepressants and how we use them. A lot of reasons why we're not paying that much attention to them anymore. Similar for escitalopram, a newer one. It's gone up some, but you don't see anywhere near the rate of rise with these medications as you do with the older ones, with the antipsychotics that are being heavily promoted.
I think it'll be interesting to see what happens with Abilify, because now they're promoting Abilify
Yes.
as adjunctive therapy.
Treatment for treatment-resistant depression. That's right. That's right. So again, Abilify is not devoid of the risk of tardive dyskinesia. It is not devoid of risk of metabolic syndrome, which is one of the principal safety factors with the second-generation antipsychotics. I worry a lot about its use, more widespread use. So this is, again, just a little bit of an illustration of that. This is just in terms of the total of dispensed prescriptions, 143 million for an antidepressant in 2004. That's gone up about 20 million in 2008. But when you look at things like the drugs for seizure disorders, which were 82 million prescriptions in 2004, gone up almost 30 million prescriptions in 2008. That's an extraordinary increase, and we don't have that many more patients with seizure disorders. So again, off-label indications and use for in a number of conditions that we're not really sure these drugs are terribly effective for. Okay, I talked a little bit earlier about what I think are the true limits of neurobiology here. I think that there is increasing evidence of a lack of common neurobiological factors underlying depression. And as I said before, when we thought this all had to do with serotonin, we know it has to do with many, many, many multiple neurotransmitters working at many different sites in CNS. And that combination of those effects, of all those neurotransmitters and all those sites, probably doesn't account for as much of the variance in terms of the production of depression symptoms that we thought in the past. We were really, really going down a very biological road, thinking all of this was very biologically mediated. This is a great study. It just happened, published a couple of weeks ago, looking at patients who had been treated in large-scale antidepressant trials. And they looked actually at genetic contributions. They did DNA sampling on these patients. They looked at genetic contributions to patient outcome. And what they found was that there were so many different genetic clusters that contributed to treatment outcome, they could not identify a single factor that was responsible. So there's no perturbation in how you, in serotonergic neurotransmission, to use a common example, that could be identified across all of these patients. There's no genetic difference in serotonin receptor subtypes that could account for a differential response to antidepressants. And their findings are very, very telling. A cumulative effect of genetic variations and clinical features. Both types of variables contribute to similar effects with respect to prediction of treatment outcome. What does that mean? It's not just biology is what it means, okay? A realization I think we knew several decades ago before we decided that we were going to put all our eggs in the biological basket. So it's a contribution of interpersonal issues, of biological issues, of genetic predisposition, of any number of cognitive variables that affect a person's outlook, their interactions with others, that create this strange condition, this strange, uniquely experienced condition that we call depression. So for us to believe that we have a unitary treatment is completely illusory. Unfortunately, that was the policy. That was essentially the policy in this country, and still to a large extent is. And it was de facto proven by the fact that almost all of our energy, research energy dollars and treatment dollars went towards treating people with antidepressants. Another excellent article that I came across recently looking at somebody's very astute predictions about where they think we're going to go in psychopharmacology. I believe that all of these predictions are coming true right now. A marked reduction in the rate of new, expensive drugs that are essentially just a molecule different than their other drugs. And what we see these days is somebody who put out an antidepressant, then they'll put out the primary metabolite of that antidepressant, market it as a brand new drug, because the patent on the first one is expiring, okay? We're seeing less and less of that as we go on. There are very, very few antidepressants in the pipeline right now. And as patents expire, no new ones are really being developed. I think you were looking at things that people realize that the treatment, that the contribution to overall outcome of antidepressants and other biological treatments is not as great as we thought it was. And we need to look at the whole treatment outcome from a variety of interventions, not just one unimodal interventions. This fellow is very optimistic, says that, gee, what he thinks is going to happen is that we're not going to send people off to a psychopharmacologist for one visit by an expert in the field and pretend that we're done with it after that. But this requires a different approach to patients, an ongoing, iterative relationship with those patients to help them, that integrate psychotherapy and pharmacotherapy to help them get better, if they need the pharmacotherapy. And then I believe that Bellmaster's right, and this is really causing us to question our basic assumptions and go back and try and figure out what really is contributing to successful treatment. So moving away from psychotropics and psychopharmacology and thinking about other things that I think are going to be driving us, and I believe should drive us in the future, let's take the example of global climate change. Up until now, if you believe, and with the new administration in Washington, we now believe that there was a human element that's driving climate change. So that is now the official belief of the government. It wasn't before. If you believe, as I do, that that is true, what we have done in the past is try and figure out how to make that better, how to mitigate climate change. However, some people who think about this very seriously, and this is an article that just came out last week in Journal of the American Medical Association, the International Response to Climate Change, argue, and I believe this is true, that if we just put all our eggs in trying to make it better, we're barely going to keep our heads above water. Hopefully that's a figurative analogy, not a literal one. And we need to start looking at how we affect behaviors to prevent, not to mitigate, the kind of thing that lead to large-scale climate change. That's going to require the assistance of people with expertise in psychological science. We know how to change attitudes and behaviors in individuals and in societies. What's the best example of the application of psychological science to prevention that anybody can think of? Two of them come immediately to mind. Studied extensively by some psychologists, a fellow named Paul Caroley, by the way, he was at Arizona State. What do you do when you get in the car? What's the first thing you do when you get in the car? You put on a seatbelt. 30 years ago, 70% of you wouldn't have done that. Okay? Where do you go in San Francisco when you want to smoke a cigarette? Outside the city limits, it turns out they want to ban smoking entirely in the city of San Francisco. You can't go any place and have a smoke. Again, application of principles, large-scale behavior change to public policy problems. Two very successful examples. But as Wiley in this article said, relationship between climate change and global health is unmistakable. It is a critical time for public health advocates to demand that political leaders not only safeguard the health of the world's population, but we need to particularly focus on survival needs of most disadvantaged populations. If you were to go to Washington, D.C., sorry, I forgot to turn this off. If you were going to go to Washington, D.C. and sit in the Pentagon and listen to military planners talk about future risks, what do you think they talk about? Nuclear threats in North Korea and Iran? Yeah. What else do they talk about? Social instability in Africa because they're losing maybe a quarter of their population due to the AIDS pandemic there, and how that destabilizes governments and creates a tremendous security risk. Okay? Other things they talk about, large-scale climate change, and how that creates social instability and tremendous security risks. So don't think that there aren't a lot of very smart people in national security agencies who are trying to figure out and mitigate the effects of these. Guess who works with those people in those settings? Psychologists do. Okay? And that's a definite career opportunity and a path that I hope that some of our students take advantage of. This is a quick graph to show you a little bit about where we are in terms of public health initiatives and where we've been expending our efforts. Between 1996 and 2006, we almost doubled the amount of expenditures for mental disorders, for the treatment of mental disorders. It is now one of the 5 most costly conditions, public health problems in the United States. Mental disorders. What accounts for most of the variance here, do you think? Huge numbers of psychotherapists out there billing at CMS rates? What do you think it is? Remember what I said earlier about the cost of psychotropics, particularly the second-generation antipsychotics? And then we had those very expensive antidepressants that came out before them. A lot of that. What would happen if you as a psychologist came in and said, and argued effectively, as you can, said, I can cut this in half by applying other effective treatments, by realizing that I shouldn't just be focusing all my efforts on using a psychotropic agent, but there are effective psychological therapies that I can apply to these conditions as well. Think about that. Think about the implications of that public health initiative, and that's something that you as a psychologist can affect directly by involvement in the public policy process. In 2007, a group called the Annapolis Coalition, which are folks that think a lot about these things, came up with what they called 7 strategic goals for the mental health workforce. And since you can't read them, I will read them briefly for you. Okay? Significantly expand the roles of individuals in recovery and their families when appropriate to participate in, direct, and accept responsibility for their own care. What does that mean? In the second, we'll discuss it in a second. Expand the role and capacity of communities to effectively identify their needs and promote behavioral health and wellness. How long does the average mental health patient spend in treatment? What is the modal number of sessions for a patient coming to a private practitioner seeking assistance for depression? 1. Okay. It's higher than the modal number of publications by graduate students in psychology. What's the modal number of publications for graduate students in psychology? 0. Be different, be different, be different. Okay? Okay? We're not reaching all of these people. We have put all of our eggs in the treatment basket. And that makes sense. We've got to learn how to provide effective treatments. But it doesn't make sense when you realize people aren't coming to get what we've so finely crafted for them. And the amount of time any patient with behavioral health or a mental disorder spends in treatment is such a short period in comparison to their lifespan. It's almost inconsequential. How do we leverage the wisdom of the community to assist that patient in the recovery process? And that's one of the things that we as a profession are studying more and more, is not just short-term treatment outcome, but what happens when we involve the community in the recovery process, and what that trajectory looks like over time, and how we can influence that rather than individual patient and therapist variables in treatment. Fascinating area of investigation, something we really need to pay a lot of attention to. Strengthening the workforce. That's a big issue. We have a lot of psychologists out there. 90,000 plus licensed psychologists in the U.S. I would say to you that I don't think that that's enough. I think it's plenty if we focus on private practice models of treating selectively identified group of patients who can afford to pay fee-for-service. I think we've got plenty of psychologists who can do that. Tell me, though, how many psychologists it's going to need for you to go onto the Navajo Indian Reservation in Arizona, to use but one example, and help people with behavioral problems that are killing huge percentages of their population via substance abuse, domestic violence, and similar issues. How many psychologists is that going to take? And do we have enough to do that? And I would suggest that we don't. Okay? We're not training enough folks in the right way. We've got to be able to train people who can provide these services, again, in and applied in those settings where patients seek the services. And then the other thing we absolutely have to do is teach psychologists, such as yourselves, to be more involved in the public policy process. That's the only way that we are going to make these changes. When we have people there, they understand the contributions and the value of psychological science. When they're not, we get ignored. So a national research and evaluation agenda on behavioral health workforce development, that's a great idea, but it can't happen without us. Just a couple of final slides here. I'm just going to reiterate what I talked a little bit about earlier, about why I think it's so vital that we look at things other than mental health delivery and specialty mental health settings. From the large scale, very large scale, and the definitive study still, the epidemiological catchment area study that Manderscheid and colleagues did first in the 90s with a series of updates since that time. At this point, in 2009, these data were a couple years before then, I think 2006 or 7. 50% of all mental health care is now delivered in primary care settings. It's a tremendous shift away from specialty mental health care. The proportion of individuals who receive any kind of mental health care increased to from 12 to 20% of the entire health-seeking population. Interestingly enough, what about that range of numbers jumps out at you? Anything spark an association there? 12 to 20% of anybody who goes to see a healthcare provider now goes to see that person for a behavioral health concern, in addition to the other things they're being treated for. What is the incidence of depression in the U.S. population, in general terms? Right around there, 17, 20%. We can argue about the exact numbers. What does that suggest? I think it suggests that the population is becoming more aware about the availability of effective treatments, and those people who are suffering from conditions like depression realize that they can seek assistance for them. This is actually a good news little slide bullet, I think. I think it's very nice. Those people who got mental health care in medical settings only, i.e. in the primary care environment, no specialty mental health, that number increased between 1998 and 2003. That's the range on these data, 154%. And of those people, those treated in community health centers, those federally qualified health centers I talked about earlier, for either mental health or substance abuse issues, increased from 210,000 annually to 800,000 annually. Tremendous increase, tremendous increase. We don't have the providers we need placed in those community health centers to deal with increases like this. It just doesn't happen. Okay? Another reason why we have to be very, very concerned about how we provide our expertise where our patients really need for us to have it provided. We got some challenges, unfortunately. And one of the big challenges that we're facing right now is there seems to be a little bit of donor fatigue, if you will, amongst granting agencies to investigate mental health issues. And there are about 9 or 10 foundations. The California Endowment is one. Robert Wood Johnson is another that provide much of the private funding for research into basic and clinical investigations for mental health problems. That number has decreased rather significantly over the past decade or so, and it is now reduced by over a third from what it had been in the past. That's a problem because these, not only do we need money for basic and clinical research, but we need a lot of funding, as Dr. Morales will talk to you about, for training of appropriately educated workforce in behavioral health care. Just a couple of other interesting things I'm going to put out to you, ways that I think that we can expand our services in ways that hadn't been apparent to us more than a year or so ago. And this is using the remote environment for treating people. This is actually a real protocol that we're putting together right now. I'm going to go to Washington in a week and a half and present it to TRICARE management activity using Second Life to assist service members in controlling obesity. So we put together a protocol where we can have you sitting here with me in a virtual environment, interacting, education, direct service provision, evaluation of outcomes for obesity. You can engage in a virtual exercise, or you can track and monitor your activities. You can engage in body modeling, so you can look at actual versus desired states. And any number of these things are now available in the remote environment. This stuff is real. It is happening now. So it's really exciting stuff and things that hopefully I'll be able to come back from Washington and say, hey, we want to get a whole lot of students involved in this. We'll see how that goes. Another issue that I think we really have to focus on in our last few minutes here, just reiterate a point I've made throughout the lecture. National leadership is necessary to make systematic prevention efforts in order to stop these problems where they start. This is a March 2009 report from the National Academy of Sciences. This deals in specific with behavioral health disorders in children and adolescents. I don't think that there's anything that any of us could say that would disagree with these findings. Targeting problems such as substance abuse or aggressive behavior, building resilience and skills and improving cognitive processes and behaviors. Operationalize that obviously a little bit. Promoting mental health through community and other healthcare programs, teaching pro-social behavior and coping skills, and promoting and providing mental health support in schools. Work with them when they're kids, really important. I urge you to look at this report because they do make some very important recommendations for policymakers about how we as a profession can engage in some large-scale preventive efforts. Judy Chu is the first Chinese American woman elected to Congress about 5 miles to the east of here. Okay? She is a graduate of CSPP LA. She is the 3rd psychologist in the United States Congress, one of only 3, and she comes from you. She's a wonderful person, by the way, and a lovely person to talk to. Be like Judy. Get and stay involved. Student government, CPAGs, APAGs. The divisions of APA are great places for students to start. National Psychologist Training Register, Association for the Advancement of Psychology. If you can't answer these questions, go home and find out the answers, because they are as vital to your future as your ability to pass the EPPP. That's all I have. Thanks very much.